Okay, so another type of CNS drug that I'm going to talk about today is your narcotics or opioids, okay? Opioids are any drug that pretty much works on opioid-like receptors, which are in the brain. And one of the most common opioids is morphine. You've probably heard of morphine already, okay? So opioid tolerance, okay? Tolerance, as I mentioned before with the benzos, right, as those are highly abused and highly addictive, tolerance means that you need to take more and more of the drug to produce an effect. Now, with some of these medications, you're going to see something called a ceiling effect. A ceiling effect means that if they do not have a ceiling effect, that means they can keep taking this medication over and over and over and over again and taking it more and more in higher doses to get an effect and it's still going to work. If they have a ceiling effect, that means you can only take the medication so much and then your body's going to have a cutoff and it's not going to really help you anymore. Okay. So it is normal and expected to build up tolerance. So that's why we have to be really careful with opioids. And, it can last for 2 to 3 weeks. Okay. Like I said, they work in the CNS and they work in some of those GI cells, those opioid receptors. So they can cause um, a lot of different things. So we have mu and kappa receptors, which are two different types of opioid receptors. Mu causes pain, respiratory depression, euphoria, sedation, and physical dependence if these drugs work on the mu receptors. If they work on kappa receptors, they're going to cause pain, sedation, dysphoria, and delirium. Okay? But just know that these opioid, sorry, analgesics are the most effective pain relievers, and they're used for more or less severe pain. So we have pure opioid agonists like morphine and codeine that work on these mu and kappa receptors. A strong opioid is morphine, moderate codeine. That means it's not as strong. We have agonist antagonist opioids, which treat low to moderate pain when administered alone. An example is penazocin, which is really good because it's not as strong as the typical opioids, but it works in those opioid receptors, which means that it's not as addictive. Okay. Now, antagonist means we block it. Okay. So a pure opioid antagonist blocks mu and kappa. So that antidote, naloxone or Narcan, or naltrexone or Revia are the reverse agents. So if we see signs of respiratory depression and sedation in our patients when they're taking things like morphine and codeine, or we need Narcan or naloxone on standby. Okay. So generally for the class, opioids are narcotics that work, like I said, on these mu and kappa receptors. They're typically used for moderate to severe pain. Pain medications, they can also be used for pain during anesthesia. Some of them can even suppress the cough and can be used to treat diarrhea. Because remember, they have receptors in the GI. And I want you to remember this forever, that the adverse effects for opioids include respiratory depression, sedation, urinary retention, constipation, nausea, vomiting. Okay? They can also cause orthostatic hypotension. Keep those in mind. I want you to know those forever. There's no little mnemonic that I have for that. You got to memorize it. Because they work in the CNS, these are CNS penetrating drugs. They cause CNS depression. So, contraindications, if they already have respiratory problems, if they already have CNS depression, allergies, no pregnancy, okay? And we don't want to give other CNS depressants like barbiturates or MAOIs or these and other ones because they work in the CNS, which can cause problems, okay? If the respiratory rate is less than 8 BPM, because normal or beats per minute, normal is 12 to 20 beats per minute, we must give Narcan or naloxone. We might also see the chest does not rise and there's shallow breathing, give this, okay? We can also give some of these, right, with NSAIDs, certain antidepressants, but we don't want to give these with CNS depressants, okay? Some anticonvulsants and some corticosteroids. Morphine is your drug of choice when we're talking about opioids. This is used for moderate to severe pain, chronic or acute pain, preoperatively, used as a cough suppressant, treats angina from an MI, okay, because we want to alleviate some of that pain, It could even be used during labor and delivery. So it acts on the CNS. So remember, it's a CNS depressant, and you could even use it on a PCA pump, okay? That gives them controlled doses of that medication. Remember, the adverse effects: respiratory depression, sedation, urinary retention, constipation, nausea, vomiting, orthostatic hypotension, okay? Contraindications: allergies, pregnancy, respiratory problems, things like that. Withdrawal. Here's the thing with withdrawal. Let's go all the way back to the beginning with this idea of tolerance. Let's just say you get tolerant, meaning you need more of the drug to get an effect. That leads to addiction. Now that means you're very addicted to the drug and you keep taking it. You have a physical dependence. When you stop taking this drug for a said period of time, maybe a couple hours, whatever, if they start to have withdrawal symptoms, such as in this case, diarrhea, vomiting, chills, cramps, pain, that indicates that they're addicted, okay? So if they're addicted, they will let's say they stop taking the drug for a little while, and they start getting these withdrawal symptoms, okay? That's a big problem, okay? So if we're seeing that, we know that they're addicted. This has no ceiling effect, meaning you keep taking it more and more and more and more and more. You just have to keep taking more of it to get an effect, but it's never going to have a cutoff level, okay? So you need an IV access to give this. Watch out for allergies, respiratory problems, increased intracranial pressure. This is all your nursing considerations. Why increase intracranial pressure? Because these work in the CNS. Those vital signs are going to tell us a lot about the patient. Are they having respiratory depression? Okay. Look at those EKGs. Priority: having naloxone or Narcan ready at the bedside in case of an overdose or respiratory depression. Monitor for psychological dependence. Are they having cravings? They need the medication. Okay. And most importantly, it has no ceiling effect. Other types of opioids include oxycodone. Okay, it's more potent than morphine. So that means it works a little better than morphine. Okay? That means if I were to give 20 milligrams of oxycodone, it would be just as powerful as if I were to give 30 milligrams of morphine. So that's why oxycodone is a little bit more powerful, okay? And oxycodone plus any sort of NSAID, like ibuprofen, is actually Percocet. Meperidine is really toxic, okay? And it can accumulate and cause seizures. So not really good. Methadone is also strong for pain. It treats abstinence symptoms such as those physical cravings, and it binds to those opiate receptors, okay? So it helps decrease withdrawal symptoms. So methadone is an opioid that helps with pain, but it actually helps decrease some of those withdrawal symptoms that we see in things like morphine or oxycodone, okay? It delays respiratory depression. It does have a risk of dysrhythmias and death, and it has a greater affinity for mu, but it helps at least mitigate some of those withdrawal symptoms, which can be good for someone who we're noticing is having a psychological dependence on this medication. Codeine, okay? Codeine can cause you to have emetic effects. It can make you throw up, but it's also an antitussive, so it helps stop that cough. It suppresses the cough, so it's an antitussive, okay? And it can cause nausea, vomiting, constipation, because remember, it's an opioid drug. Dexamorphine, right? It's an antitussive, but it's a non-addictive type of opioid, okay? It's a morphine derivative, so it is an opioid. That's why it's an opioid-like drug. It's an antitussive, meaning it suppresses the cough reflex like codeine, but it's not addictive, which is really good, especially if someone has a bad cough and they need pain relief. Hydrocodone, you can combine it with acetaminophen, and it's actually good for children. Hydromorphone or Dilaudid is a very commonly given medication in the hospitals. It's a good choice when there's too much opioid volume. It's safe in renal failure, okay? And it's an alternative to morphine, right? If they can't really handle that, we can give them hydromorphone or Dilaudid. Oxymorphone, another one. Thing with this one is we don't want to take with meals. Heroin, diamorphone, is so much more potent than morphine. Very big problem. The antidote for heroin is naltrexone. It's not Narcan, it's naltrexone or Revisa. Fentanyl, another really popular opioid. It's highly potent. It can be used transdermally, and if we use a transdermal patch, you must use it with gloves, be very careful with children, and change the sites, okay? It's 100 times more potent than morphine, so we have to be very, very careful with that, okay? Advantages of the transdermal patch is that it's good with patients with poor compliance, and it's a good choice if you're worried about drug abuse because it's not really addictive. But the disadvantage is that since it's topical use, it takes a little longer to work. Okay, and if it's exposed to children, they can go into an overdose and die. So you must wear gloves and dispose of this very carefully. Always remove the old patch before you put a new one, and they're kind of expensive. Okay. Um, Another drug that I want to talk about, it's not a first line agent, but it can also be used as an analgesic, and it has a lower abuse potential, which is good. And this is called pentazocin, okay? You can give it orally, and it's really good because, like I said, it isn't as strong as the other sorts of opioids that we have out there. So we might give this one, but it's not a first choice. And we typically use this for moderate to severe pain, relief of pain during labor, okay? But it is still an opioid, so it can still cause respiratory depression, sedation, constipation, urinary retention, nausea, vomiting, all of that, okay? Nothing really changes between the classes. Just knowing how to recognize them is very, very good, okay? And this one has a ceiling effect. So that's why it has a low abuse potential, which is really good. That ceiling effect prevents it from, you can't overuse it because it'll reach its limit and it won't be able to do its job anymore. It'll only do the maximum amount that it can. We already talked about naloxone. It's a narcotic antagonist, meaning it blocks mu and kappa, which means it binds to those opioid receptors without activating them. So it treats those if they have an overdose in these opioids or they have a dependence on alcohol, and it can reverse the symptoms of these narcotics. Very, very important, okay? So the thing is, it can cause low tachycardia, blood pressure changes, dysrhythmias, hypertension. So we really need to watch out for those vital signs, okay? And naloxone, it enters the breast milk, so no pregnancy. Other medications that I just want to point out to you that also work in the CNS or work in that autonomic nervous system is that we have different types of headaches, right? And sometimes you say, hey, take Tylenol, but we have different types. We have migraine headaches, which are severe and throbbing, and they occur on one side of the head. That lets you know it's a migraine. If it's a cluster headache, it's usually in men. It's a sharp, steady pain that you feel in the eye. And if that's it, and they have nasal congestion, they have a cluster headache. Tension headaches occurs usually during times of stress, and it's a band all around the head. Now, Igor derivatives cause these constriction of the cranial blood vessels, so it makes them really tight. I've told you before, constriction helps with pain. Dilation makes pain worse. So it constricts those vessels, helping with the pain, and decrease those pulsations of those cranial arteries, okay? So they reduce perfusion to the brain in a way. And an example is egortamine, okay? So these Igor derivatives actually help prevent migraines. That's what I want you to know about these drugs because you might see them. Drug-drug interactions or beta blockers just on where they work because these block actually those alpha receptors. And they cause like numbness and tingling and arrhythmias because they work in the CNS, okay? Now, triptans are another type of drug that works in the brain. It actually affects those serotonin receptors. And actually, Igor derivatives also affect serotonin receptors. That's why they work in the CNS and they're also CNS drugs. We have relief of migraine from these too, but these do not prevent a migraine. Okay, Igor derivatives prevent migraine. So that's what I want you to know. Any drug that has an Igor ending, right? So egortamine, like that, they prevent migraines, whereas triptans relieve migraines. Okay, that's what I really want you to know. And that with the triptans, they usually have triptan endings and they can cause dizziness and nausea. Okay, like sumatriptan is an example of a triptan. And the reason I brought these up because these are medications that you use that are also CNS acting drugs, but these affect headaches. So remember, Igor derivatives have Igor in it and they prevent migraines, whereas triptans have the triptan ending and they relieve a migraine pain. They don't prevent one.